It's amazing. We're all singing from the same hymn sheet. We're all just singing at a different tune or a different pitch. Just to put it into perspective, in 1983, in my first year as a medical SHO in North County Dublin, I was in call in the Richmond for the whole north side of the city, anything north of the Liffey, and I remember going on call with 0 or 1 bed. You know, that's what you had for the whole North City, so I don't know if things have changed greatly since. Anyway, I'm in a 7-man practice in a primary care centre in Gorey, County Wexford, one of 3 primary care centres in Gorey. For its population, I think we're very innovative. The interesting thing is all were funded privately. The most important thing for today and anything to do with healthcare is that the patient is the central focus of everything. Everything revolves around the patient. The left-hand side shows the resources. That's the department and all the people who fund into health funding. And on the right-hand side, you can see that we have primary care and secondary care. But then we're fighting against public expectation, which is a huge problem, and the patients all believe now that they should have their 2 holidays in the sun, they should be able to see their doctor every day, they should be able to go to their hospital every day, have everything done in 5 minutes flat, and everything is sorted. It's not quite like that. We've known for a long time that medical inflation goes way beyond society's ability or willingness to pay for it. The point I wanted to make is that primary care centres are buildings. They're not a team. You can have a stadium, but if you don't have a team, you're in trouble. So I think we have to develop teamwork with our colleagues in the ancillary services. And that, the barrier, as Mike said, is quite hard to break down. But if we have the proper mental attitude, I think it will happen. So this was just to show you that it's not all bricks and mortar. And this is the Aviva Stadium being built. And then Kevin Costner in the Field of Dreams, he said, if you build it, they will come. Now, I think there's a slight difference between the view of the Department of Health and maybe the 20 to 30 practices who've gone ahead and developed their own practices. They think that if they build it, people will come. You don't get the team by just building it. I think you have to do a lot more work than that. So what I'd like to say is we have huge resources out there, and we have huge, because primary care is so good, we have great goodwill factor. We have vocationally trained GPs who have been trained for 4 years, who have a great skill set, but I think it's not being used in primary care at all. We have joint injections, we have marinas, minor surgery, chronic disease management. Phlebotomy I just threw in there just in case the Minister was still here, because we did 1,600 warfarin tests last year and didn't get paid for it because we're 27 miles from Wexford Hospital. But that was just my dig. So the point I'm trying to make is that all these things can be done in primary care, and there's lots of other things. The models have been proven that the cost savings are phenomenal. I mean, there are still orthopaedic colleagues who are bringing people into minor theatre at a VHI cost of probably 600 to 700 to do a minor joint injection, which can be done in general practice. So once again, you'll save at every level. Right, I just put this up because it's been mentioned already, the cost of investigations is incredible. And what we have is we have people coming in with minor illnesses who are being sent off for all kinds of investigations which are totally unnecessary. Once again, as a junior house officer, I had one of these guys who was definitely going to be a consultant gastroenterologist. And I remember doing a ward round, and the only fun on the ward round was the registrar had to outguess the consultant to see what test the consultant would order. So he had to make sure he'd ordered every test in the book, so when the consultant turned around and said, have you done a serum tapioca? Oh yes, I did that. And they used to have this little game to see who could think of a test, all of which was costing huge amounts of money. So I think, you know, if you've an arrow in your head, stupid, that's what it is. So we shouldn't be over-investigating. And I think it behoves us to know the cost of investigations. It also behoves us to know the cost of drugs. All the way through medical school, no one ever told me how much it cost in prescription costs and fee per item on a private and a public prescription. No one ever told me about the cost of mixing drugs for antibiotics. No one ever told me the fact that there was VAT on anything that didn't go into your mouth. And yet we were asked for quite a number of years to run drug budgeting. If you want to save money, you should understand, I mean, what are we worth, what do we prescribe each year? Hundreds of thousands. We should know. If we can save that by 5%, that's money that can go for the patient. Open access, vital. Radiology, phlebotomy, stress testing. I mean, what's the point in sending someone down to your local hospital to be seen by a doctor who is qualified, and I'm not saying anything about my colleagues, but may have been qualified 2 to 3 years, who says, yes, Doherty was right, you do need that. We'll organise that for you. 6 months later, you have it. You then go back again to be seen for the result of your test. You have 3 useless visits to hospital. That should all be done, and we should be able to sit down and do that. Once again, massive savings. Patient education, not very expensive. We started young in Wexford. So, I mean, we have groups, different groups who are more than willing to help us. So there's huge openings in education, and if you start young enough, you can modify lifestyle. I mean, the patient who comes in, pretty much all we can do is we can give them a cholesterol tablet because they won't stop smoking, they won't lose weight, they won't do anything else. So, I mean, media campaigns, getting in when people are young, all of this will save huge monies to the health service. IT was already alluded to. I mean, we have different software in almost every hospital in the country. We also have 4 or 5 different softwares in the GP or primary care setting. We need communication pathways. We need to be able to refer directly to hospitals. We then need to know, there's no point in me sending a letter to a hospital and not knowing that the patient is going to be seen for 8 months. This is the duplicity means that I have patients going to Wexford Hospital, Waterford and Dublin, all of whom I've sent letters. The reason being that the outpatient visits are 2 to 3 years for certain disciplines in certain hospitals, which is, we don't know unless they tell us when the appointment is for. As a result of this, you get huge duplication. So I think it was on the last card, I think we need to have smart cards. I think if the patient information is on a card, then you're not going to have the duplication of investigations. So once again, it comes to thinking outside the box. Infrastructure. The Minister was talking about the change in the hospital settings and the downgrading of certain hospitals. Once again, that can't be done without proper roads and ambulances. 40 miles from Dublin, there was a patient of mine that had a stroke. It took 2 hours before the ambulance got down, got him and had him back in Tala. I was on call Sunday week, child came in fitting. We have an ambulance 1 day after 6 and on Sundays, 1 day in 3 or 2 days out of 3. So the ambulance had to come from Wexford. So what do? You put the patient in your bloody car and drive to meet them. I mean, it sounds like it's, you know, that should be 1940 stuff, but that's the reality out in the street. So we can't ask for primary care or secondary care to be reconfigured without having the backup. We're only looking for trouble. Non-medical therapies, I think we need a lot of, once again, group education. Physiotherapists, as was mentioned already, can do a lot of the work of the orthopaedic surgeons. They can also do group treatments or group sessions for people with back pain, shoulder pain, so they can save a lot of resources. Diabetes, National Diabetic Day, I think we can do an awful lot at primary care level for diabetics. It's the obvious model for multidisciplinary teams, and I think we're only beginning to realise that, but we need a little funding in the community for it. I just thought I'd put this in. Everyone's talking about fast food, and yesterday the Minister was talking about, please stay, the Minister was talking about putting a tax on sugars and sweet things, but that's a new version of fast food anyway. We have things coming down the line, community intervention teams. I think once again this would be ideal for primary care. This is just to show you once again, going back to 82, 83. I was in a Dublin teaching hospital and my boss broke his leg in a riding accident, and myself and the registrar were sitting down and we said, isn't it very strange that you see these people on a 6th of July and you tell them to come back in 6 months when they're seen on the 6th of January, knowing bloody well that the next houseman will be seeing them, so there's no continuity of care. And we said, most of these people don't need to be here at all. So we sat down, and over the 3-month period when he had his broken leg, we discharged half his outpatients, which was perfectly reasonable. Most of them were private patients who were coming in, and if they got the prescription, then they didn't have to go to their GP. So they were being seen by a junior doctor and getting the prescription and saving themselves £30 or whatever. The medical card patients were coming in for a chat. If you didn't like the guy who you knew was going to follow you in 6 months' time, the really cranky ones, you'd make sure they definitely didn't come back within a 6-month period. But the consultant, when he recovered, came back in and he says, where are all my outpatients? Because it's kind of a status symbol the size of your waiting list. We said, we discharged them. Most of them are perfectly stable, nothing wrong. We had to write to them all and invite them back. Fact. Okay, so I just thought I'd put this one in because we were talking about acute care, and the only point I have to make about this is that about 30% of the patients we're sending to hospital are people that we can't get outpatient investigations for. And I think we can, just like you've shown in your acute case, we can reduce these figures phenomenally. And one of the things is country boundaries. I'm 4 miles from the Wicklow border, which is Eastern Health Board. Theoretically speaking, in Gorey, I'm Southern Health Board. So if you cut your finger, have a tendon injury, welcome to Cork. Might be the nicest place in the world, but Vincent's is 45 miles up the road. So, but they have an X-ray system in Arklow, funded by the Eastern Health Board. And when we went into the primary care team, they said, no problem, you'll have access to this. Each GP has in Arklow, even if the patient lives in Gorey, can get their X-rays done same day, report same day. I have to wait 2 weeks for an open access chest X-ray and 3 months for the normal waiting list for any kind of X-ray. If the patient lives in Gorey, but their GP is in Arklow, they can still get the investigation. I mean, where's the equality in that? 10 miles up the road. So I think we have to realise that open access will save a fortune in money. Well, once again, the economy is stupid. It's all about money, but there are savings to be made, which has been adequately demonstrated. And secondary care cannot be changed until the primary care is ready to take the load and that we have all the ancillary services necessary. It came. That's all I have to say. Thank you.